herself or himself, and we'll have some time, I suppose, for questions and discussion, but we will all be here, so we'll have the chance to talk after this session too. Welcome again, and we can start. Would you like to? Yes, thank you.
Yes, and we'll have two speakers today, and as Dr. Villy said, we will then go ahead and open up for questions. We'll be moderating, we'll be asking questions, but if someone in the audience has a question, please let us know. We'll bring a mic to you so everyone can hear. All right?
Okay. Thank you very much. We can start with Dipali Ye, Assistant Professor, Department of Physician Assistant Studies, Rutgers University, USA. So, the floor is yours.
Okay, I'm going to be your masked singer. No, I'm joking. Yeah. So thank you so much for inviting me to come speak here today. My name is Dipali Ye. I'm an assistant professor in physician assistant studies, and I'm also an adjunct professor at the Ernest Mario School of Pharmacy. My clinical background is in emergency medicine and trauma. I've been a physician assistant for over 20 years. And it was about 15 years ago that I was actually introduced to the concept of interprofessional practice before I was introduced to interprofessional education. And it didn't come from my job as being a PA. It came from me being a mother. I do have some slides here that might be medically triggering or graphic. There's some content here about the history of medicine in the United States that might be a bit triggering, so I would be remiss if I didn't tell you about that, right? So this is how I came to be introduced to interprofessional practice. When you think about something that happens, that changes your life, that is true to your heart, those are the things you follow in your profession at times. My father always said to me, if you have a job doing what you love, it does not feel like a job. You're simply doing something fun every day. For me, that was not motherhood early on, but when our youngest son was diagnosed with a condition that required brain surgery for him, or skull surgery, you can see in the top photos as a 12-week-old how long his head is. So he was born with a condition known as craniosynostosis. So the skull in our babies is in pieces. He was born and they were one big fused unit, right? So what is the problem with that? Well, as he grows, his brain needs room to grow. His jaw might have trouble. His teeth might have trouble. So there's a lot of issues that can happen with this. So we went to the Children's Hospital of Philadelphia, and we saw a neurosurgeon there. His name was Leslie Sutton. Logan was his last patient ever. He retired at 10:03 a.m. when Dr. Sutton came out of the operating room. He was officially retired. So my son was his last patient. So he took Logan to the operating room, and the first thing I noticed was this. As his mother, I had to go with Logan. So we're wheeling into the operating room, we're standing there, and here is this regionally well-known neurosurgeon, right? Everybody knows him, well published. And the OR nurse said, hey, Dr. Sutton, stop what you're doing. We are going to do a timeout. Now I'm just a mother there. I didn't know what was about to happen. Here was this guy, this neurosurgeon, Harvard educated, who said, okay, I'll drop everything to do a timeout. And the timeout was, what is the patient's name? What is the mom's name? How old is the baby? What is the procedure we are doing, right? Because we don't want errors. We don't want to do the wrong surgery on the wrong body part, so we are going to do a timeout. And this nurse was able to get this doctor to stop what he was doing for something as simple as a timeout. I could not believe it. This was some time ago. Logan is now 11 years old. That was the first step. The second step was when I was getting ready to go to the hospital sent my husband and I education. Look at a PowerPoint, look at this video. And the video was to learn how to do something called an S-bar, S-B-A-R. Situation, background, assessment, recommendation. For me, I'm not there as a PA, I'm there as a mom. But whenever they did rounds in the morning, they came right to our bed, to our crib, and they did rounds with us. And every single morning round, for the time that we were there, ended with the team turning to us and saying, do you have any questions for us? Every single time. We were so involved in Logan's care. We were never dismissed. So when I left Children's Hospital of Philadelphia, I really felt compelled to learn more about interprofessional practice, really. And in delivering this talk, my mentor, somebody I respect a lot, Dr. Scott Parrott, kind of encouraged me to look a little bit further. Now here's this guy, Alexander, right? I'll call him Alex. We'll call him Alex. There's a lot of Alexes in American history. This particular Alex was not a clinician. He was an educator. He actually grew up in a German-Jewish immigrant family. He was the first one to go to college, and he was so good at what he did that the Carnegie Foundation said, this guy knows what he's talking about. I would love for him to go around the country and look at all of these medical schools and see how they're doing and see if we can unify them, accredit them. Can we make them better? This is back in 1910, so over 100 years ago. Abraham was kind of tasked with looking at medical schools around the country. Are we doing okay on the sound here? Yeah, okay. So one of the things he noticed was there was a lack of unity. This medical school was doing things differently than this one, than this one, than this one, and all of this was important because science was booming, medicine was booming, right? And we were learning all of these wonderful new things. There was a larger expectation of medical students who were graduating. They really had to dive into the deep sciences. They really had to practice. How do you come to a diagnosis? How do you become a medical detective? And he wanted to make it better. I'm going to move this one away. I'm not sure if that's influencing it. This was not an easy job. This is early 1900s. So he went by motorized car, he went by train. This is a long travel. It's a big country. He visited over 150 schools. And in doing so, he really told some of these schools with criticism. How many people are willing to accept criticism, especially when you're an established institution like Harvard Medical School? So what he wanted to do was invest in unification. And these were institutions that were so sensitive to the criticism they were about to receive. He was not received with a red carpet. There was no fanfare at all. And this is what he found. Physicians were ill-trained. The graduates that were going into the medical schools were not prepared. There was a maldevelopment of these clinicians. And this was hard because now they're focusing on the sciences if you think about what they're doing. And then when they went into clinical care, it was not balanced, right? When you're a medical detective with your nose in the books, it's hard to translate that to how you talk to a patient. Now his intentions were good. He really did have good intentions, but what was the result of it? It led to marginalization. So what does that mean? Of the majority of black medical schools that existed, only 2 remained open. And look at the number of clinicians in training that dropped. That was one of the results. There was a couple of results in addition to this. He told black graduating physicians, you can only take care of black communities. He told women physicians, you should only go into OBGYN. You should only go into pediatrics. Additionally, following that, the physicians were now at the top of this power hierarchy. The doctor was the only one in charge. And really, the only other people involved were nurses. Let's move 100 years later, about 100 years later, and out comes another report, To Err is Human. This was a landmark report. I want you to hear the word preventable. I'm going to say it again. Preventable. This landmark report said 100,000 deaths in the hospital are preventable. Imagine that, 100,000 of them preventable. And what was the cause of those errors that took place? Lack of communication, hierarchy in medicine. All of the things that Flexner created were now leading to some of these errors 100 years later. So what does this mean to you? When I first started teaching IPE, it was in a little tiny trailer box at the physician assistant program about 12 years ago, and I only had 48 students. And it grew, and I taught the School of Dental Medicine and the Department of Nutritional Sciences, and now I collaborate with the Physical Therapy Department to teach IPE. And now our entire School of Health Professions learns it. This is why I'm now here on the other side of the world, because you are our change agents. You are here to help us change the culture of medicine. Flexner had good intentions, but your voice needs to be heard. If you're a PA, if you're a physical therapist, if you're a speech and language pathologist, if you're a nutritionist trying to protect your patient's airway, I want you to know that I want to empower you with leadership, that when you're on a medical team, you should speak up and you should say, hey, I'm worried about something. I'm concerned. Can we talk for a minute? I'm asking for a culture change. Culture change doesn't come easy. It takes years, decades, hundreds of years. But our hope is that this is the beginning of a culture change that really starts with you. Because when I was in PA school and my husband was in medical school, we never got this training. We did not have the opportunity to learn this early on and then learn how to do it when we became clinicians. Yeah. Sure. You have to lower the... Is that better? Okay.
Yeah.
I'm almost done.
Carry on.
I'm not just saying this to you because of my own experience. This is not just hearsay. There is a substantial amount of evidence, 40 to 50 years worth of evidence that proves that when we mutually respect each other, when we listen to each other, when we remove the hierarchy, not only do we reduce medical errors, but we keep our patients safe. And I gotta tell you, I love my job, but if I'm not happy coming to work, then my patients aren't happy, and my team isn't happy. So your job satisfaction matters, and you want to work in a place where your voice matters, where you can advocate for your patient. And what I'm asking you to do, what we're asking you to do, is to reshape healthcare practice and to make it more meaningful. I want to end with Logan. I want to remind you that Logan is doing just fine. He's now 11 years old. He is a wrestler. he has a huge scar that goes ear to ear. And whenever people ask him, what happened to you? He just tells them, oh, this is my superhero scar, because I'm a superhero. So, that's it. Thanks, guys. Sorry about all the AV issues. Yeah. Dr. Perry?
So, first, I'm going to pull rank here and ask a question. My guess is I'm probably not going to use this, but I'm going to play devil's advocate for a second, all right? Clinicians are always working together, right? They're always, almost by necessity, practicing interprofessionally, all right? You're going to see the nurse, then you're going to see the doc, you're going to see the PA. We're talking about something qualitatively different, all right? Something that, because I can imagine, you know, folks who aren't American and sort of currently being drilled into their head, thinking, well, we already do this. What is it that, if you were to pick out a key differences, what is it that makes this particular approach to interprofessional practice unique, different, and as you say, hopefully institution changing?
Thank you. No, that's a great question. When I went to PA school, we took all of our basic science courses, like microbiology, chemistry, with the medical students. And actually, the physical therapy students, we all took our classes together. And then we broke off into our individual professions, and we didn't see each other again for years until we hit the hospitals or the offices or the rehab wards. And then we forgot how to work together, right? So if we're going to do this, and if we're going to do it right, if you need to know the anatomy of a shoulder, your sits muscles, right? If you need to know what the circle of Willis in your brain looks like, if you need to know the maneuver of how to teach a patient to get out of their bed after they've had a stroke, you should know this just as well. This is just as important, if not more important, than any of those things. And the reason why this is different is because see, it's interprofessional. It's teamwork. This is different because I never learned this. I'm a really good PA. If we get a 27-patient bus accident, I'm going to know what to do. He is a really great anesthesiologist. He actually saved my life on a ship a few months ago. But if we don't know how to talk to each other, none of it matters. And you can't do it once. You have to practice it over and over and over again. And you can't practice it just sitting in a lecture hall. We have to put you in a simulation lab, and we need you to live it. And we need to have you take care of a patient, an actor, and go get a history, and do a physical, and do it over and over again as a team. I put our PA students in a simulation lab with pharmacy students, and I guarantee when I get my evaluations back, every single time my PA students say, this simulation was not good because the pharmacy students were missing, and we can't work without them. Now this is their culture. They cannot live without their pharmacists. And that is what I want to do. I want to make you feel like the team you're on is as important to you as your left and your right hand. And I want you to do it for years before you become a clinician. And then the next student group that comes along, you teach them. And we do this for a couple of 100 years. That's all it'll take.
Okay, thank you. Yeah. Are there any questions? Any questions? No. Are there any questions from the audience? Anyone? All right. In that case, thank you so much, Dr. Gay. And that one's
yes, fine. So we go on with Matthew Matsaganis, Associate Professor, School of Communication and Information of Rutgers University, USA. Beyond Silos, Reimagining Interprofessional Communication for Collaborative Care.
Okay. Hello. Good. Yeah? Okay. Good. Good evening. It's always good to have a presentation before you by someone who maybe not in communication, but does a wonderful job presenting, includes all the hallmarks of a fantastic presentation, including a very compelling personal story. So thank you, Dipali. So Dipali and I are colleagues at the same university, but a very different part of our campus, and so I'm at the School of Communication and Information. My work is at the intersection of what we call health communication and organizational communication, but I'm interested in figuring out the role of communication in creating and perpetuating health inequities, so disparities or inequities, and then figuring out how do we design and implement communication-centered interventions to eradicate those kinds of inequities. And so while I don't have a clinical background, and I don't often work in clinical settings, I usually work in community settings, urban community settings for that matter, I come to the issue or the subfield of interprofessional practicing communication because I've had to study and work with anything from social workers to physicians to a number of other types of clinicians to address health issues in community settings, both in Greece and in the US, but also as an educator working in the field of health communication, which is really interdisciplinary. Health communication brings folks in from communication, from public health, from medicine, and so all these individuals have fantastic expertise in their field, but may need a way to talk with one another. So that's a bit about my background, but I wanted to actually use Dipali's call to make us all better change agents, and I'm hoping to add a little bit to help you a little bit in that direction by talking a little bit more about communication.
And before you do that, use the one that streams. This is the one that is streaming.
Okay, so, no big change there. Okay. So I'm thrilled with you to be with you today, and so I'm going to begin with a little case. So think about this. I have a 62-year-old patient who was readmitted to the hospital due to having been given mixed prescriptions. Okay, so two providers were involved in handling this case, both competent, both acting within their professional boundaries. They both had access to electronic health record systems, patient portals, if you use another term, a bit different, but a similar term. So these were available to them as resources, but they were not used collaboratively. And the result was kind of a breakdown, not of competence, but of communication. And this is not rare. Dipali alluded to this earlier, but we have data suggesting that, actually data fairly recent from 2022, suggesting that up to 66% of sentinel events, so these are serious events, negative or adverse events that affect patients, can be attributed to some level to the lack or to communication or miscommunication. And so let's kind of think about the idea of interprofessional communication. Having a definition may help. And so we should think about this not as this casual talk between healthcare professionals or clinicians, but instead as the structured interaction, right, across healthcare disciplines that are focused on shared and patient-centered goals. It happens in meetings amongst clinicians, it happens in chart notes, during hallway exchanges at the hospital, the health center, you name it, and during handouts when patients are passed on from one medical team to another. When it's either change hospitals, when there's a change in shifts, those cases where handoffs take place. And for interprofessional communication to actually work, it requires clarity, timeliness, mutual respect, and critically a shared understanding. And so we think that interprofessional communication matters, and it matters to everyone. It affects patient safety and patient outcomes and satisfaction, but it's a daily lived experience for clinicians, an area which is ripe for exploration for communication scholars like myself and others obviously that have similar interests. And finally, interprofessional communication is systemic. It's not just about interpersonal missteps, but it also has to do with system-level breakdowns that end up affecting patients, their clinicians, and of course their caregivers, families, etc. So I'm going to make an argument that communication is not something the saying goes that we cannot not communicate. Others say because that is true, it's like fish trying to study water, so there's nothing to study here. And I'm going to say that it's quite the opposite. That we do require, it is something that requires intense and careful study. And we can develop frameworks, theoretical concepts, theoretical tools, if you will. I won't use the word theories because it's off-putting, particularly for those of you that are younger, and which totally understand. I teach a class of communication theory of 200 students every spring, and when you say the word theory, and you see all these eyes glaze over, and then by the end of the semester, they're usually, at least half of them, are persuaded that these are seen as conceptual tools that they can use to make sense of communication-related phenomena in their personal life, their professional life, and organizations that they're a part of, et cetera, et cetera. So I think that sort of working within and applying various kinds of communication, theoretical, conceptual tools is useful. For a few different reasons. First of all, they're useful for making sense of complexity. Some of the phenomena that, one thing that Dipali mentioned, with a number of other cases we could talk about, the example I gave you in the beginning, can be fairly complex. And so we need conceptual tools. So these are frameworks that have been developed through intense and ongoing and research. So data-driven development of theory that allows us to reveal hidden dynamics in team communication. It helps understand where the breakdowns happen beyond the interpersonal interaction between clinicians and, of course, clinicians and their patients. We also want to make sure that theoretical concepts give us a way to talk to one another. We use the same terms because we use the theory of the conceptual framework to communicate about a particular situation or case. And using the theory, we can derive diagnoses of what went wrong in a situation, and therefore develop solutions that speak to those specific problems. And finally, sort of working with specific conceptual frameworks allow us to empower or enable systemic change. It can guide us in developing interventions at the organizational level, at the hospital level, at the healthcare system level, and otherwise. And of course, it can support sort of better coordinate care in clinical settings. So frameworks are not just ideas, but they're tools that can facilitate and enable transformation. I'm going to give you just 3 brief examples of what I'm talking about here. So one of these frameworks is the IPO. It's the input, process, output model that helps us understand how communication transforms tools and training into outcomes like coordination and safety. Think of communication in this context as the engine moving the system forward. So we could think about here so what is the process that so we have in clinical settings, we often work in teams, right? So a team is a kind of a structure. What are the processes that the structure uses to accomplish its goals? So these are the processes. And what happens as a result of that, right? So now we have a basic tool to break down a phenomenon that involves patient care and involves clinicians talking to one another to address this patient situation. This is one example that comes from mostly from organizational communication research. Another one that is quite useful in several situations, communication accommodation theory. In this case, this looks at how people adjust their speech, their tone, or vocabulary based on the context, especially when talking about across hierarchy. So for example, how a junior nurse, for example, might speak to a senior surgeon. This can build rapport, but also can reinforce power gaps in this case. Finally, in terms of, next is theory of structuration, kind of a complicated theoretical framework used in a number of different fields, but communication here is not just what is shaped by organizational routines and norms, but in fact, it reshapes them as well. It's kind of a cycle. Every conversation is an opportunity to reinforce or shift norms and expectations within teams. So for example, increasingly so in clinical settings, we're using various electronic healthcare record systems where clinicians enter a bunch of data about the patients that they're seeing every particular are used to follow up with them in the future. Now, these systems are complicated. They can make the life of clinicians very difficult. And so we have abundant research right now that shows us that in various clinical settings, to avoid the complexity of the system, to avoid how much time it requires to enter data, process data in these systems, clinical teams develop norms around how they use it to make things better, make life easier for them. And we call these workarounds. Now, these workarounds get created through communication. Clinicians talk with one another and figure out, okay, how are we going to modify what we're doing here while using the system to accomplish our goals and satisfy the requirements that exist that we use the system to do our job. So it's a kind of how norms and structures affect communication. It's a bidirectional relationship between communication and structures within these organizational settings. The fourth framework I'm going to just mention very briefly, it's just not a theoretical framework per se, but it's rooted in empirical research, is more practical. This is called team steps. We have Deepali is one of our resident experts, if you will, and so we'll be talking more about this in the coming days. But it's a toolkit grounded in theory, offering strategies like the S-bar, which Deepali mentioned earlier, huddles and checkbacks to standardize and strengthen team communication. Despite the fact that we have these tools, they're not used very widely. Yeah, we need to do more in that direction, and because of that, barriers continue to persist. So we have discipline-specific jargon that makes clinician communication quite difficult and problematic from time to time. There's role ambiguity, there's power dynamics, time pressures, tech overload, and cultural mismatches that make clinical communication, interprofessional communication more challenging. And these are not isolated problems, and they compound one another. So how do we improve interprofessional communication, right? So we start with the shared mental models, using some of the theories I mentioned earlier, for example, but also using structured tools like the S-bar and closed. Interprofessional education is key, as are the feedback loops and inclusive digital systems. And we must prioritize psychological safety so that team members feel safe and comfortable to speak up when things go wrong and things need to be addressed in a particular situation. So this is where collaboration between communication researchers and professionals on one hand and clinicians on the other becomes quite essential. So the scholars or the researchers bring the theory, the systems, thinking, and analytical tools, but clinicians bring practice, insight, and immediacy to the table, and together we can design smarter tools ranging from video analysis to patient portals, grounded though in real-world dynamics. And so to close, interprofessional communication isn't a side concern, right? It's central to care. And the frameworks that I've shared with you today help move us from theory to action, but this work is collective. And so I go to leave you with a question, which is, how might you contribute to reimagining collaborative care? And this is just one of the central questions we're going to address in our summer school that we're working on. We actually just began today. It's a collaborative effort between Rutgers and Democritus University of Thrace. We'll be here for the next 9 days here together, where students from Democritus, students from Rutgers, students that have very different professional and educational backgrounds are coming together to discuss persistent and emerging issues in interprofessional communication. And so we thank you for hosting us today, and for hosting us for the next 9 days as well. And so with that, thank you, and I look forward to our conversation.
Again, any questions? Hi, And again, I'm going to play devil's advocate. And because you were making us feel guilty about theory, I'm going to do it from a structuration approach.
Okay.
I was trained reading Gibbs, so, you know. But doctors, MDs, are usually the first and the last in terms of legal liability when there's an error on the team, okay? So I would suggest that what that does is that sort of external structure, the legal system, is going to put limits on, let me be blunt, what sometimes feels like this happy holding hands, we're all communicating well approach, because, you know, if my profession, my sort of, you know, practice, my wallet is on the line, why do I need to listen to people who I believe are less qualified for me? And so how are we going to approach a situation where we're trying to create this bubble of productive communication when there are external pressures from other institutions that are actively working against that?
Well, I think, I guess from a like physician's point of view, I guess, I think, or the person that has the last say, right, or has the most say, I think they need to kind of realize, based on the data, that actually better interprofessional communication leads to better outcomes, leads to more satisfied patients, healthier patients, fewer readmissions, and so their safeguard, actually, it's in their interest to do more of that, to facilitate and invest in interprofessional communication, because it is onerous, it is more work, it does require developing a common language, and God knows that it's difficult to do, even if you're not talking in high-stakes situations, right? Even more so if that's the case. But we know we have a fair amount of data suggesting that if you put in the time and do the investment, that the outcomes are going to be consistently better. And so it is an upward, it is an well, it is a battle, but I think it's worth fighting, and I think we have the tools to make improvements in that direction.
Hold on, let me get you.
So the question I have is more related to how those who aren't physicians can take this initiative. So how those who are non-physicians can take this initiative, because I've been a dietitian for 24 years, and I've definitely noticed a change in the hierarchy and structure and communication in the time that I've been a professional. But I work at a pretty major hospital, and I feel like a lot of people I know that might work at smaller institutions, they can be like, well, this is great, but how do I get the physician to communicate with me and to adapt this model? Is there a way to, I guess, how would you encourage the physical therapists and the nurses and the dietitians and the, you know, whatever profession to bring this concept to their team?
Yes, I think, well, you may have ideas about this too. Yeah, we were discussing this earlier a little bit with the Dipali, and so I'm sure she has. I think it's difficult, right? Because you have your job to do, you want to keep your job, but at the same time, it may not be the situation may not be ideal, right? And so it really has to come from the top. The top needs to be sort of invested, understand that this is important, and put effort into facilitating this kind of growth, if you will. And so probably we talk about like how do you get like STEAM steps to be adopted by clinical settings. And so you want to talk a little bit about that, what works in your sense from adoption?
I think in terms of adopting something like this, and believe me when I say that I have been met with a substantial amount of resistance, it does exist. There's this concept, I think, definitely I've heard in our country, I don't know if it applies here, is shoot first, ask questions later. So I do agree with Matthew, you have to start from the top down. You have to get buy-in from your leadership first. Unfortunately, many times it doesn't work that way. People want to make these changes because something already happened, because a baby died, because the wrong leg was cut off. And I'm telling you, we're talking as recently as 6 weeks ago this happened. So sometimes it's more reactive, and in doing so, individuals like us who are experts and will become experts have to keep pushing the culture change. That's really, it's not an answer, but it's an answer. Yeah.
And I believe we have another question.
My voice. Sorry, I apologize. Hopefully, I can't even talk. Hopefully you can hear me. So you put up a slide, 3 circles intertwined. What was it? Physician?
We only had 3 circles, right? So yeah.
Physician, nurse, and what was the third? Pharmacist. And so I saw that, and every time I see, and this happens many times, that nutrition or dietitian is not on the list of choices, but we do have physical therapy, and we do have pharmacists, and we do have all these other allied or integrated health, but nutrition is consistently marginalized. So I know from experience in the smaller hospitals, even the larger hospitals, that it takes a great amount of effort and time and just fighting to get certain things that need to be taken care of to get the attention. But I strongly feel, and maybe I'll learn different during this conference, during this study abroad, but I strongly feel that nutrition is the underdog. So.
Yeah. No, I agree, and I didn't mean to, I didn't do it on purpose. I didn't think when I put the image up, I didn't make the image, so but it is a good question, and it's a great question to talk about in terms of like how does context matter, like what happens in the U.S., what happens in Greece. And I think Riva, our colleague, one of our co-designers of the program, who's also dietetics expert as well, we had a long discussion about sort of how the position of the dietitian in the U.S. has shifted in the positive direction, playing a more central role in decision making around when it comes to patient care. In Greece, there's a lot of space, a lot of growth to be pursued in that direction. But maybe we can discuss that further in our coming class meetings as well. But it's a good question. Okay, I don't want to.
Okay. So we go on with our colleague Milena Raffi, who is associate professor at Unibo, University of Bologna. We collaborate with Milena Raffi. The presentation, you have to wait, my dear. Interdisciplinary educational protocols developed by DO's project and Traveling Well-Being, a project to disseminate healthy lifestyle among commuters. So, my turn. Thank you. Here you are.
Thank you very much.
This is collaboration.
That's a very good example of collaboration. Okay. Okay, so, well, thank you very much for the opportunity to present our projects. And so, as I introduce myself, I am Milena Raffi. I'm an associate professor at the University of Bologna, Italy. And my background is on neuroscience, mainly neurophysiology. So, in this period of my career, I slightly moved to the health and public health topic, especially on prevention and various activities that can be used to the prevention of non-communicable disorders. So here we go with DUSE. DUSE is the acronym of Counteracting Diabetes Using Interdisciplinary Educative Programs. It's an European project founded by the program EU for Health. And I hope to be able today to give you some good example of interdisciplinarity and collaborative partnership. So I give you a little bit of a background about the project. So why we need the DUSE? We need the DUSE because the diabetes is really spiraling around the world. So right now, those are numbers from the IDF Atlas of 2021. We are about 1 out of 10 people worldwide with diabetes. Most of them are undiagnosed. So it's a very difficult and complicated situation. So diabetes is mostly seen in low and middle and low income countries. So that's why it's a really a urgent issue to solve worldwide. Those are the projections. So sorry, these are the numbers and these are the projections. So right now, we have about more than 500 million people with diabetes, and the projection for 2045 are a little less than 800 million people. Another big issue is the health expenditure, because as you can see here, this is the health expenditure in billions of dollars. You see North America, Europe here, and Western Pacific. So those are billions spent for diabetes and its complication. So this burden of diabetes, let's say, places individuals and communities in a very dangerous situation. So this is our motivation for enforcing its prevention. Of course, we cannot do it by ourselves, so we need the collaboration of several experts and several professions. Why we say that we need collaboration? Because, of course, we are talking about type 2 diabetes. Type 2 diabetes is largely preventable. I say largely because in some cases it could be genetically driven, so it could not be totally possible, but in the large majority of cases it is preventable. Because type 2 diabetes is a problem of lifestyle. So wrong habits like poor diet, obesity, or inactivity increase enormously the risk of type 2 diabetes. So we can prevent it by healthy habits. So we have literature supporting that significant probability through habits can improve health of everybody, basically. So this is our approach. So basically, because given that changing unhealthy behavior during adulthood is challenging and is also very difficult, we tried but we failed in most of cases, we thought that establishing healthy behavior during childhood would be much more effective. So that's why we are acting on kids with 3 pillars. The first one is to develop educational programs on nutrition and physical activity, then to support the educator and parents, and the third one is to use gamification and digital technology to engage and activate kids, because right now kids love to learn through gamification. So the general objective of DUSE is to promote educational strategies to prevent non-communicable diseases such as diabetes. Our target groups are first and second grade kids, kids in risk, so kids who already have pre-diabetes or obesity, infancy obesity. And also we are acting on Ukrainian refugee children because the war situation made the School activity is very limited in Ukraine, so we thought to reinforce, at least in some cities, the good habits that these children could bring for their entire life. Our actions are school interventions, lessons on healthy habits, on several types of healthy habits, gamification with the technological support, family involvement in lifestyle change, and scientific approach to measure the impact of our program. So those is strongly interdisciplinary. We are located, our consortium is located in 4 countries. We start from, our host, the Democrito University of Thrace, and they have experience in physical education and in teaching protocols. Another partner is Sports for All Association in Suceava, in Romania. They work on sport education and in teaching physical education. We are partner of Athena Research. Those colleagues work on information technology and digital research. Then our hospital is the Sant'Orsola Hospital in Bologna, and we collaborate with the pediatric endocrinologist. League of Tolerance in Ukraine is an association which work with inclusion through sport and school teaching, and the University of Bologna. And our team, we work on public health, nutrition, and physiology of exercise. And you see, we have very different backgrounds, and we are very happy to work together to develop the DUSE protocol. I will show you some example very soon. So I will start telling the collaboration between IT experts and clinicians and professors, because the question could be why digital tool in education. Right now, gamification is very important because all kids learn better through play, and digital school can make learning fun. You see also in our lessons in the university classes use VooClap. In the school, usually they use another device which is called K something, Komoot or something like that. But anyway, kids like playing with interactive digital tools. So the idea for DUSE was to use mobile app for interactive learning and activity, especially for young kids, and the application gamification because they connect the real world and digital rewards. Kids really like rewards. Also, the idea is to encourage self-activity in children. Like, they start playing and they play for what we ask them to play. So, in other words, our goal is to make them doing what we want them to do. The scientific background supporting DUSE is because the European projects, European purpose and European calls, and the World Health Organization strongly encourage the use of digital technology for the promotion of health awareness. So this is a kind of interactive learning is very important for ameliorating behavior and attitudes. So we created altogether gamified mobile app for first grader. It's a very nice app. Maybe we will be able to put it on Play Store in few years. So kids will play physical activities and nutritional contents within the app. So there are 3 or 4 games regarding nutritional contents, and several games for physical activity. So the app drives the activity of the kids. Another important protocol that we developed is the use of MIT App Inventor technology. So App Inventor is a technology invented by MIT in Boston, and it's a platform. Is similar to Scratch, if you are familiar with Scratch. The main platform for small kids for having learning the digital coding. MIT App Inventor allows the person to develop personal app. So what we did was to teach the kids how to program mobile apps and ask them to produce their own app. So in this way, our idea was, okay, they will work through IT, they will work through a platform of digital contents, but reinforcing the context of health. So they, for example, provided food diary, or provided apps counting pieces, you see. So they were left free. They had freedom to choose which kind of app to produce. But, you know, for the first year, we got at least 50 apps, so I think kids like it. Other examples of interactions in our protocol is the work with the nutritionists. So here are two of our nutritionists. She's Bianca and she's Ginevra. And the nutritionist made lessons in school at small groups of kids, you see, because in small groups of kids, things come out to be more effective because they don't feel the pressure of the whole class, but they are comfortable in making questions. And this is a super fancy thing that we invented. So you see here one of our teachers in the school. So our colleagues from the hospital, the pediatric endocrinologist, put the glucose sensor to the arm of the teacher. And here is the application, like the one for diabetic people, the application on the phone, so the teacher could directly show during the classes in the school the effect of the food. So like, for example, eating a soda full of sugars or eating an apple. So, you know, in 10-15 minutes, the glucose level was showed on the phone. So it was a direct way to interact between clinicians and teachers on health promotion. In other situations, in other countries, what we did was cooking lessons in schools, supervised, of course. And here you see our chefs with the production and these wonderful creative dishes that the kids made. So another way to interact with the kids is to show everything in an unconventional way. Last but not the least, of course, is the physical activity lessons. So in all countries, we promoted physical activity through outdoor lessons or activities in the gym. So you see 4 classes of the high school playing volleyball, basketball, and doing exercises, and that is the outdoor activity. So we try to engage them, reinforcing the contents even through physical activity. So those are our numbers in the first year of the project. So we enrolled a total of 463 children in 4 countries. So we hope to be so successful next year because, well, if we would reach 1,000 kids in 4 countries, we would be very satisfied. So as final remarks, I can tell you that the integration insights from various disciplines like physiology, physical education, medicine, public health, behavioral science, nutrition, and technology in this era can be useful to create more comprehensive, culturally sensitive and sustainable strategies, educational strategies. So the collaboration not only enhances our understanding of the factors contributing to diabetes prevention, but also empowers communities with innovative and tailored solutions, because just to share something with you, the nicest part of this project is the creative aspect, because we really work all together. We have worked all together in the designing, even in the pre-proposal of this application. So it's really nice to get together every 2-3 weeks discussing from different points of view, because new ideas always come out. So for the future, fostering interdisciplinary partnership will be essential to all the activity to reduce the burden of diabetes. Of course, we can open this or not refer this only to diabetes, but to other pathology, and improve health outcomes on a broader scale. So this is our contacts, the main contacts of all participants in this project. This is a project website, and thank you very much for your attention. We need to share the microphone.
Yes, we are thinking of going on and then asking questions, because we are a bit late, not to get anxious, but so we could go on, and the questions. Thank you so much. Okay, go on, please. Why did you stop?
Well, because I thought that you wanted to take questions. Okay. Okay, the next. Yeah, the commuters. Okay, so well, this presentation will be quite short because well, thank you very much for the opportunity to show you this project as well. This is a very this project is at the beginning stage, very beginner, and it's nice because it's a project to disseminate a healthy lifestyle to commuters. Because being a commuter is not easy. This is an Italian project at the moment. So according to the Italian National Institute of Statistics, there are over 3 million of commuters in Italy, and more than 200,000 are just in our region, Emilia-Romagna. So commuters have problems because they are stressed. They could be anxious several hours a day, or showing depression, and for our interest, worst situation is a sedentary lifestyle. Because of course commuters spend a lot of time during each weekly day sitting on train or on buses for even hours a day. So we try to help commuters basically. So this is a grant from the University of Bologna, and the goal of the project is to raise awareness and offer practical and effective tips to make things better. So basically what we did is the tentative to transform the commuter moment, so the time spent in commuting, into moments that could be beneficial for both body and mind. I want to reach with this goal, so we created a website dedicated to the promotion of physical activity, health, nutrition, and mental well-being. So there are videos on trains, on commuter trains, and we show through this video several contents to the commuters. So in each content, the commuter finds a QR code, so the commuter can connect to this QR code to the specific content. So basically, we promote physical activity with articles and videos. For example, to explain how to perform postural exercises during the commute. We also show healthy nutrition tips, like promoting recipes, for example. And also mental well-being is promoted, providing both article and tips. So this is an example of the website. You see the main bar. So here you see movement for well-being. So the person pressing specific links can reach the specific contents. Just want to show you one example, if it works. Okay, you see now we went directly on the website. So there are exercises here. Okay, no, it doesn't show what I see here. So I don't see on the main screen what I see here. Well, anyway, I can describe. So if you click on the button here, sorry. If you click on the button, you are forwarded to a specific set of exercises, for example. So now the trick is to go back. Okay, do you see? Okay, fantastic. This is another example for health nutritional contents. If we are late, I can forward. The idea is the same. And also, on scientific purposes, we ask the commuters to fill in some questionnaires, specific surveys of course, nice feedback for us, and nutritional habits and information about daily habits. So again, this project is strongly interdisciplinary because we have a collaboration with several experts: biochemistry, nutrition, psychology, physiology, health prevention, kinesiology, exercise, and pedagogy. So we all work together to improve life of commuters. Of course, this is a very, very beginning project, and also, but we think that there is room for making it a bigger project, both at European level and maybe also more cross-country level. So thank you very much.
One minute, please. One minute. No. technical problems. Maybe.
Αυτό είναι βγαίνει, αλλά δεν παίζουν το άλλο.
Όχι. Όχι.
Anyway.
Τι συμβαίνει?
Δεν υπάρχουν comments.
Α, τα comments. Στα comments σε βάλει. Προβολή εικόνα, θέλεις, Αυτό είναι...
Right. I will proceed. Good afternoon. I am Nikolaos Angelousis. I'm a professor of biomechanics in this department, and I will present an interdisciplinary approach to the rehabilitation of balancing gait disorders. Well, balancing gait disorders affect millions of people globally, and especially older adults. The impact is severe because it is a factor for increased fall risk and injuries, and they reduce mobility and result in social withdrawal, and additionally it raises the healthcare costs and the caregiving burden. So the treatment of balance and gait disorders is not just has not only clinical relevance, it also has societal relevance. Now, this is the scheme that presents the rehabilitation cycle, which is a structure, a systematic procedure involving 4 phases, 4 steps. In the assessment step, the problems and the needs of the patient individual are identified. In the assignment, the assignment to appropriate measures and interventions and to appropriate professionals takes place. In the intervention phase, the appropriate intervention, the program is planned, coordinated and implemented by appropriate professionals or teams, of course. And finally, in the evaluation phase, the achievement of the goals is evaluated, the level of the achievement, and a decision is made whether this is the end of the process or an additional cycle is needed. Now, here we see the causes of balance and gait disorders. The causes are, a lot of causes can produce balance and gait disorders. Neurological situations like stroke or Parkinson's disease, musculoskeletal degeneration, vestibular problems, visual, cognitive and psychological, cardiovascular problems, and even side effects from medication. So not a single discipline can address all these issues in order to treat balance and gait disorders. And this is not just a checklist. It's a map that demands collaboration, interdisciplinary collaboration. So, with the department, along with the Department of Medicine of the Demokritos University of Thrace, our department recently conducted a project, the NeuroBioStroke project, and the goal of the project was to study the correlation between neuroimaging, neurophysiological and biomechanical biomarkers in order to inform subject-specific, individualized rehabilitation programs. And we brought together more than 20 different disciplines. Again, now I realize that we, dietitians and nutritionists, again, were not included in the, I never thought of that, okay? But anyway, useful. Involving neuroimaging specialists, biomechanics, physical therapists, exercise science, neurologists. And it was not an easy task to make all the different disciplines a team. It took us more than 6 months just to start working as a team. And we needed more than the first year to be productive and perform the procedures that you're going to see. Before starting with the assessment phase, this is a drawing that summarizes the postural and gait control mechanism, and all of this should be assessed in order to decide which is the appropriate intervention in each case. So we have to employ neuroimaging and neurophysiological methods to study the integrity and the structure of the nervous system. And at the spinal level, the central commands from the neural system are organized in muscle synergies, which can be assessed using electromyography and kinematic analysis. At the muscle level, the final muscle signals refined by the spinal reflexes also can be assessed using electromyography and ultrasonography. The forces produced by the muscles that act on the bones, on the skeletal system, can also be measured or estimated using dynamometry and musculoskeletal modeling, while the stresses on the bones can be assessed using finite element methods. Then posturography, gait analysis, and coordination analysis are used to quantify the way the subject moves. And finally, motor performance are assessed using balance and movement or functional scales. And all this data, which are multimodal in nature, has to be analyzed and discussed from the whole, all the team members have to participate in the discussion in order to decide possible interventions to bring optimal results. And of course, in order to perform all these assessments, you need state-of-the-art laboratory and equipment. And in this project, we employed the two laboratories, one in the General University Hospital of Alexandroupoli, and the other one within this department. And the assessment involved first neuroimaging assessments. We performed voxel-based morphometry, and in order to quantify the gray matter, and diffusion tensor imaging and tractography in order to quantify the integrity of the upper motor neurons, the white matter. Also, we applied resting state functional MRI to quantify the neural networks, mostly the motor networks and the language networks, which are responsible for specific deficits. Neurophysiological assessments involved polysomnography and diagnostic transcranial magnetic stimulation, and the assessment of autonomic nervous system. These assessments are usually neglected in the rehabilitation of balance and gait disorders. We applied many scales in order to perform the clinical assessment. You cannot go solely based on the laboratory measurements. You need to perform clinical assessments using scales. And we used a lot of scales, starting from the National Institute of Health Stroke Scale, the Berg Balance Scale for balance, time-up and go test for agility. We even assessed cognition and depression status, and all of this were taken into account prior to make the decision about the appropriate intervention. In terms of biomechanical methods, first we examine the static balance, because you have the ability to perform well in steady state conditions if you want to move. Then we also assess the reactive balance, which measures the ability of the subject to regain its stability after perturbations, and we induced artificial perturbations to measure the subject's performance or adaptation. During quasi-static assessment, we assess the ability of the subject the ability of the transition from studying to moving. And finally, we conducted full gait analysis, in order to quantify all the parameters that are critical for movement, kinematics, kinetics, muscle forces, stresses, and so on. And all this data were analyzed, and appropriate interventions were decided. Now, within the intervention, along with the pharmacological treatment and psychological support, for subjects with motor deficits, mostly, we applied two kinds of interventions. First, the neuromodulation techniques, and specifically repetitive transcranial magnetic stimulation. This method is used both for diagnostic and for treatment purposes. And it stimulates specific brain areas using electromagnetic pulses. And this is proved, not totally, but many believe that it promotes neuroplasticity, which affects positively affects stroke recovery. And in the video, we will see the core of the physical training of the rehabilitation from the rehabilitation program. This regimen focused on neuromuscular improvements, on strength improvements, coordination, balance, and let's see it. And this is the result. On the left, we see an individual before the intervention, the gray figure. We can see the asymmetrical gait pattern, the spasticity in his left upper limb. And on the right, we see the same subjects after 3 months of the rehabilitation program. We see significant improvement, clinically relevant, no reduced asymmetry, and very reduced spasticity in his left arm, and a more confident movement pattern. And I believe this, this outcome confirms the central message of these presentations. To treat a complex problem, you need interdisciplinary collaboration among different experts. Of course, each team must have a leader, and who has to have the final decision. In our team, the leader was a neurologist during the acute phase, and a physiatrist during the subacute and chronic phase. Thank you very much for your attention.
Νομίζω έχει reunion. Όχι, για το χρόνο που έχουμε, αν έχουμε. Αυτός είναι ο δικός σου υπολογιστής. Yeah. Νομίζω ότι έχουμε πάλι πρόβλημα με τον τύπο της παρουσίασης. Ποιο να πατήσω. Ξέρεις τι γίνεται. Το σώζουμε από τη μία τέτοια, δεν τη διαβάζει. Το σώζουμε άλλο τέτοιο, δεν τη διαβάζει. Τι δεν λέει. Τώρα τι να κάνω, βάλω το δικό μου. Δεν μπορώ το δικό μου. Δεν ξέρω, το συνεδρίο.
Και απλά δουλεύει.
Δεν ξέρω τι γίνεται σήμερα με τα δικά μου τα αρχεία. Το σώζω το PPX, δεν παίζει. Το σώζουμε πάνω. Το σώζω...
Και στο δικό μου πάνω...
Τι γίνεται, εδώ. Γιατί? Να το. Τι να κάνω τώρα, να φέρω το... Να φέρω το... Μπορεί και να πω και απ' έξω.
Ένα λεπτό θα πάμε.
Well, and while Yannis is trying to serve me, I don't know, it's the second or third time today, I will start saying that, remember the DOS project that Milena presented earlier? My presentation has to do with a similar project, but in a national level. I think it's not a coincidence, it's just a necessity that relates to obesity and the dangers that come from obesity. So it's a national endeavor, a national project. It's called the National Action Against Children Obesity. And in fact, we collaborate with the Ministry of Health, the Ministry of Education, many universities in Greece, local authorities, schools, and everyone that works in education. So we are trying at a national level to to provide, to help people become aware of obesity and how we could act in order, altogether, in order to lower the levels and prevent health problems. So in this project, we collaborate, our department, my department, Department of Physical Education and Sports Science, collaborates with the medicine school where Professor Kodogiorgis is working, so of the Democritus University of Thrace. So we have developed a collaboration, a very nice collaboration, and we, until now, we have held two workshops for teachers, for school teachers, and also directors, school directors, about this national action, which includes two toolboxes with 4 strategic goals. It's targets. It's physical exercise. It is sedentary behavior, avoiding sedentary behavior, drinking water, and also having snacks and lunches whenever it is to have them. So. Under these 4 pillars, let's say, we are trying to collaborate with all the stakeholders, even with sports clubs or municipalities, in order to not only to provide the awareness workshops, but also to teachers, but also to parents and other stakeholders, and to it doesn't work. Okay, I knew that. Well, thank God I know it by heart. So we are trying, in fact, yesterday we had here the health festival, a health festival with 300 students from kindergarten to 4th grade. So they participated in several physical activities that related to these toolboxes and the physical activity part, but also to the food pillar, to the food toolbox, through movement and through activities that are interested and they liked a lot and they had a great time. Of course, these actions are only some actions. It's just to wake up, I think, all of us. Until the end of December, we are planning a lot more actions and synergies with all these stakeholders in order to go on with this project. And also, we'll have 2 schools to operate as hubs. So we will have a certain program that these schools will implement with the collaboration of all the stakeholders I just mentioned. But our vision, and I finish with that, is not just to have a project like DOS and another one in a national level or another one, but to think of the sustainability of these actions. So what we are trying to do in collaboration with the Ministries of Education and Health is to make all this sustainable through the educational programs, through the programs of study of the schools. And one of these programs that is strongly related to all this is the program of physical education. But also in other disciplines, there are also topics that relate to both to physical activity and to nutrition and to avoid sedentary life and to drink water. So we are trying to establish a collaborative and interdisciplinary approach through education. That's our ultimate goal. Thank you very much. You are superheroes. Well, I'm afraid we have to leave because there is a reunion here of the students of 2005. I don't know if we have a couple of questions, maybe. Yes, okay. Here you go. I know you have written everything. So you.
Well, actually, I do have a few questions. Actually, one for Nicholas. It was fascinating how many disciplines you had up there that were involved in the research. It wasn't clear to me how many disciplines were involved in the actual therapeutic part. You know, we saw a lot of what we would call physical therapy or maybe occupational therapy. But, you know, you remarked on the role of vision. And at Rutgers, we're doing a project where we're addressing both visual acuity as well as gait. So that caught my eye. What other aspects of the therapeutic part of the work you are doing besides physical therapy are there?
Well, according to the deficits. If we had cognitive deficits, then neuropsychologists and psychiatrists were involved. If we have vision problems or vestibular problems, then we have ophthalmologists on the this was the General University Hospital. So even if someone was needed that was not in the project's team, then we have his cooperation in treating the situation.
So the team was based on the needs of the particular patient?
It was based on the estimated needs. Before the team was created, before the project starts to seriously be implemented. So we estimated, according to epidemiological data, what are the most possible situations that we had that we might have to treat, and we selected the disciplines. Again, we forgot the dietitians.
Yeah, I noted you had a lawyer on there too. I'm afraid to ask about that patient, but. We have to be very careful about the regulations, because according to Greek regulations, they are very strict regulations. Not a single patient can be assessed if he is not accompanied by a physician. The physician has to be during the whole assessment. Okay. And that was a major problem because all physicians in Greek hospitals have very heavy workloads. It's very difficult to have them 2 hours waiting for us to assess the patient. Okay. All right. Well, thank you. Did you? No. I was really curious about the DUSE and one, I found the Journey to Wellness an incredibly clever title for what you're doing, and I would love if you could share that with us. I really want to see those exercises. You know, some of us commute, and I would love to share it with our students because I know our students commute as well. So I really appreciate to see that. So, and with that, anything else from anyone? Matthew.
Okay.
So thank you for sharing your very interesting projects and very ambitious as well. So thank you for that. I had two kinds of questions. One had to do with the project on diabetes, and so I know that one of the two challenges that we face with mHealth or eHealth interventions has to do with how do you facilitate adoption of the application or the device, right? And then how do you maintain how do you keep people using the application over the course of time? I mean, usually these fail very quickly. And so I'm wondering what you have done or what you foresee doing to further encourage adoption and keep the kids using the application in the future. That was one question. The other had to do with all the projects. I mean, there's you have colleagues from various disciplines, which is fantastic. And in true European tradition, research tradition, you have colleagues working from various countries as well. And so this is fascinating, but I really wanted to hear you talk a little bit more about what makes these collaborations work. Like what happens behind the scenes on the everyday life of the project that facilitates interprofessional and interdisciplinary collaboration over the course of 2, 3, 4, 5 years, which is the life of these projects. And so those are my two questions.
Okay, so thank you. Okay, well, so the answer to question number one is right now for the younger kids, they the one who are supposed to use the app, we haven't reached that level yet, so we are just showing them the app and we collect data while they play with the app. So we have no data yet about how much time they can keep spending on the app. This is let's say, a goal for the second year to see for how many months at least they can play without getting fed up, basically. Instead, for the older kids, right now the situation is that we ask them to play and to develop the app just sort of homework. You see, we thought, actually we told them to keep creating the apps because they can sell the apps through Play Store or iOS or whatever. But yes, it's very early and we would like to have a few more years of testing for this, but this is a very good point. So yeah, we all should make everything more detailed for not losing the path, actually. And answer to question number two, that's a very brilliant question. So actually, Vasiliki and I and all colleagues in the Democritus University of Thrace have been partnering in two projects. DUS is the second one. The first one, it was called BNew, started in 2020. I would say, to be honest, that what makes a collaboration across European countries and different disciplines is the desire to work together. That's it. Because we had in a previous project a partner or few partners who were not so keen to show their knowledge or to collaborate in a strict point, like showing data and analyze data together. I also had this experience in the past, and things don't work, basically. So I think the real challenge is to find people who wants to work together with you and your project, and then go.
Thank you. Christos. And then you want to...
I promise I'll be very short. Because I know that we have very limited time, and to be honest, I wouldn't like to make a question, just like to make a final comment. And I would like to thank Professor Michalopoulou, because when the first time we discussed about our summer school, she told me, okay, it's a great opportunity to join summer school, an international conference. And at the beginning, I was a little bit surprised, but she was very right. Because as you can see from all this discussion, we have many points of common interests. And we have a lot of space to work together, even though we come from different fields, from different backgrounds. So I would like to thank you, Professor Michalopoulou, thank you, Professor Deri, for giving us this opportunity to come closer and to discuss such things together in this very interesting, very nice conference that you have organized here. Thank you very much for being here.
The pleasure is ours.
Okay, the closing has been handed to me. Thank you all. Thank you for your attention. Thank you, presenters, and look forward to working and talking with many of you in the weeks to come.
Outside.
Outside, that is. Where there is beer. Yes.